Good morning, total therapy solution. That's what I say when I answer the phone. Good morning, PT Breakfast Club.
Do you take my
Dave
insurance?
Kittle, Jimmy McKay.
Do you take my insurance? What time would you like to schedule?
Totally.
Dude, I went from working at a radio station in New York for 2 years to working at my first big break station in Pennsylvania. And my boss brought me in on a Saturday because he was like, oh, like not as many people are in the building. It'll be less stress. My first mic break, I turned the microphone on and I said the name and call letters of the last radio station. So he buzzed me on the phone. He goes, that sounded great, but that's not the name of this radio station. I was like, son of a what? Not a good way to start.
Wow. So we have some interesting topics.
I know. This is a good lineup.
I was just reading the prospectus. So you guys bring me back to reality. What are we talking about?
All right. So Hinge Health is filing, they're going to try to IPO. And I think we all saw Larry Benz had like a nice little take on it. I like when smart people break it, not dumb it down, but break it down. Listen, there's this big steak. Could you chew on it a little for me so I sort of like understand it and then give me the edges? And what he was saying is, listen, Hinge's S1 filing, he's saying what's not in the filing. It's us. So he's saying if you sort of scroll through all those things, which I guess Tony was just doing. See, I told you.
Oh, I'm sharing the link right now across everything for the S1 filing.
So this is what they have to file to get approved to then go public. I just want to make sure I understand how a bill becomes a bill.
Yeah, basically it's like the plan. It covers, what I was reading was the risks to the business. I thought they were interesting. I think that's where the most valuable information is.
Really? Okay. All right, let's dig into this. But what Larry was talking about was, hey, listen, if you read it, their claim anyway, or their marketing has been saying digital physical therapy, but physical therapists aren't actually included in there. So it indicates that Hinge Health directly employs physical therapists to provide in-person therapy sessions. Does not indicate that Hinge Health directly employs physical therapists to provide therapy sessions. Instead, their model revolves around digital interventions and support from a care team, which may include health coaches and other professionals, but not necessarily licensed physical therapists delivering hands-on care. This feels like a lot of times when we hear in physical therapy or Facebook groups, when someone says, so-and-so down the street in my community is marketing PT, but I looked and I called and there's no physical therapists there. Who do I get angry to? This is that, but like on a pretty big, on a digital wide scale.
Yeah. I understand what he's saying. He wants to protect the human element. I know Dave and I have talked about this before. I've talked to physical therapists that are employed by Hinge. I'm always impressed by the therapists that I've talked to. I think they're doing an amazing job. For some reason, Dave, correct me if I'm wrong, I thought somebody had said, like, you and I had talked about them firing physical therapists.
Right.
But I thought that like one physical therapist managed something like 700 plus cases, or the physical therapist was primarily involved in developing the treatment protocols, which I love that model. I'm not going to take anything away from it. What do you remember, Dave?
That was what we heard also from, who did we have? Julia from Sword Health. Yeah. And it was a similar situation.
That's what it was. Yeah.
So let me just ask you, Tony, the S1 is 250 plus pages.
Yeah.
And as per Larry Benz, and I didn't do the search where you can search a document and search a keyword or whatever. Control F. Thank you. If you do Control F, it does not mention physical therapy and it does not mention physical therapists. Tony, I need your response to that.
No, it absolutely mentions physical therapy a ton of times. It mentions physical therapists a ton of times. I'm not disagreeing with Larry. I understand what he's saying about he's basically saying it's not about hiring physical therapists to deliver physical therapy. And that's probably true. But it's a technology platform. It's not a physical therapy clinic. They're effectively hiring physical therapists to develop treatment protocols that can be carried out. The patient's first kind of, line of defense is, hey, okay, you've been diagnosed with this, or you have these symptoms. Let's try this intervention. Hello, we've been doing this, not me, but with stupid PDFs, 6 ways to treat your low back pain for 100 years.
Right.
I know they haven't been around that long. But yeah, there's absolutely therapists, licensed therapists on staff. My understanding is they're developing the treatment protocol so that every single person who logs into Hinge doesn't need a direct human's attention. Most of the problems can be handled just like self-checkout, just like, you know, all the other technologies we have today. Like, why a physical therapist with your kind of experience, Dave, is still trying to help somebody that has a condition that could be answered with an automated chat makes no sense.
I hear you. Maybe you or Jimmy want to put this on the screen, but there were some good comments under Larry Benz's LinkedIn post. Stephen Goosetree, he said, Hinge Health is a tech company first, healthcare company second. They prioritize going public over the well-being of their PTs. One of the many reasons that he left was that they began offering clients a la carte options, maybe what you're just describing, or maybe not, where the client could begin exercise therapy without a proper assessment from a licensed physical therapist. Zero clinical reasoning or yellow/red flag screening being performed. Clients would often get worse from self-start programs and then schedule a physical therapy evaluation. And Stephen ended it by saying that he is glad that Illinois passed a bill this year where telehealth physical therapists must have a brick and mortar option to refer patients to if indicated. What are your thoughts on that?
I mean, I think there's some biases in there, you know, no doubt. So I pulled it up on the screen. Yes, I agree. Tech company first, healthcare company second. I'm a billing company first, healthcare company second. There's clinics out there that are marketing companies first, healthcare company second. I shared a post. It was a poll. And I said, look, if you're a business owner operator, 1-person team, you have to prioritize regulation and compliance over the care delivery. Like 30 or 40% of the patient or the therapist responded, no, that is not true. Of course it's true. I said, once you grow more than 1 person on the team, you can put somebody in charge of compliance and regulation. But the reality is we're talking about what we want versus what actually has to happen. So I would say, yes, they're a healthcare company first. Yes, I think it's awesome they're offering a la carte options. I don't understand how that would be, how that comes at the price of the therapist or whatever was said there. PT evaluation. I don't think, you know, this goes back to, okay, I can buy a shirt, this shirt, small, medium, large, off the shelf at Walmart, or I can pay a tailor to custom design a shirt, to choose the fabric, to measure my neck, my chest, my belly. Like, that's going to be $500. Off the shelf is going to be $12. You know, I can go to YouTube and get physical therapy exercises for free. I think Hinge is better than YouTube. Jimmy, you and I shared a study that showed something like Hinge or Sword or any of them with the option of an actual therapist. It had better results than, you know, Hinge without or therapy alone.
Right. I remember that.
There was another comment by this guy Yogesh, and he said, if it makes it more cost effective, great. And then he said, especially for 70 to 80% of cases where in-person physical presence is not necessary. And then I replied, I said, is there any data or surveys or research that helped you come to that conclusion of your statement of 70 to 80% of physical therapy, call it outpatient, or, you know, musculoskeletal cases, 70 to 80% of those cases where in-person physical presence is not necessary? And he has not replied with any surveys, data, or research or anything like that. So I don't know.
Do you want to know why? This is my guess. Scroll back up. Scroll back up.
Well, he did reply here, but okay.
Because he's the digital innovator, right?
Because it was written by AI. Nobody writes I'm not saying he didn't like copy paste and write it, but whenever you start that first post up top with blah, 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 blah as a game changer, that screams AI to me. It screams ChatGPT.
So
trust me, I've played around with it enough.
The response here from him, My statement about 70-80% of cases in person presence is based on digital health industry studies. However, their studies show the effectiveness of digital and in-home. I mean, all this stuff is, research does not generally apply to real life. And we're talking about population numbers as opposed to how does this affect an individual. Now, I totally agree with Dave. I think if this wasn't free to the employee, I don't think they would care. I don't think they would use it. I don't think they'd pay for it out of their own pockets. I think the key to their success lies in the fact that the employer or the insurance company is paying the bill, not the consumer. I think if the consumer got stuck with the bill for this, it would not work.
Why is that, Tony?
Like you said, because if I'm the consumer, it's not just about it's honestly not just about the outcome. It's about the experience. And so if I'm going to buy something, if I'm going to pull out my wallet and pay, I'm paying for, the experience that I'm going to receive. I can get across the country 100 different ways, but I don't want to walk, and I don't want to ride a bike, and I don't want to ride a horse. Like, I'm going to pay for the thing that I want. And then I'm going to balance, okay, I can drive, or I can fly, or I can take a train, then I'm going to balance like what is the most efficient, the most effective, plus what makes me feel good. I don't think anybody really again, you can go to YouTube to find most of the solutions to your pain problems.
So are you saying that the digital experience is not much of an experience, or a subpar experience compared to in-person physical therapy? Is that what you just kind of hinted at?
I think people won't pay for it. I think it can be just as effective.
If they don't, I agree. So if they don't pay for it, then that means what?
Well, hang on.
Go ahead.
It's a subpar experience.
Bail me out, Jimmy.
I think there are parts. Like if you had back pain and you knew that you could log on and there was this thing you had access through a portal where you could get Dave to pop on the screen and help me feel better, or just lead me to the next steps, like concierge access, right? Like that's sort of what Dave offers, which is like, hey, can I get, instead of driving to the urgent care and waiting an hour because I can see online their wait's 90 minutes, oh man, and it's a half hour away. Could I get someone to talk to me and look at me? I think that, but I think the long term, the longer experience of it, especially in PT, I don't know. I think it doesn't feel as good.
Jared said, not sure if this applies to Tony or Dave, but now that Jimmy shows all things RCM.
All of it. I know everything RCM. Challenge me.
Wondering if anybody has a ballpark average reimbursement rates for RTM.
Don't even worry about it. It's
payers,
peanuts. It's peanuts. It's
yeah.
Peanuts. Don't even worry about it.
I mean, the last time I looked at some of those codes, it was
it's a joke. It's a joke.
Like $20 for an eval or a setup. And then I think it was if you did everything.
That's a bridge toll here in Brooklyn. I mean, it's not a big deal.
Right. Well, here's the thing though. So hold on. And I'm going to do an episode with Matt Jurek again in a couple of weeks. Matt, if you're listening, we will set that up because we've been pinging emails. I think the math, if you did everything right, was $290 per patient per quarter. And I'm taking that from a company, not, research. But it was if you did everything right and you did factor in your time as your cost. So what, I don't know if you guys heard my episode with Matt, he essentially was I'll handle the setup and the organization of it. You do the care. He was your quarterback. And then you came in and you managed your patients. Because that was the first thing everybody looked at with RTM, which was now this is an email game and I got to track the juice doesn't feel like it's worth the squeeze. As these apps get more savvy, I think it'll get better, but the rates aren't going to just skyrocket. It'll get easier to scale this, I think.
Let's save RTM for a dedicated.
Yeah, that's a different.
I agree with those numbers that you said. Jerry, of course, asking the wrong question. I remember
Jerry's commenting the wrong words.
For what? Who's asking the wrong questions?
No, the thing I love about Jerry, I remember, it was 10 years ago, maybe. Jerry was ask better questions, get better answers. There's been a common theme. Jerry also says the same PTs complaining about payment want to keep the status quo. I agree. We can't keep living in 20, 30, 40 years ago times. Like, we need to move forward. We need to adopt the technologies. Now, if you guys remember, we also talked about, okay, we've got Hinge and we've got Sword. Most of the employed patients who come to my clinic, they get the same mailings saying, hey, free physical therapy online, come check it out. Okay. I acknowledged to Dave already, it's not what somebody wants to pay for. They're not going to pay 30, 40 bucks because the app isn't going to rub their back. I will rub their back. I don't care if it's effective. How do I say? I don't care if it's research based. It makes them feel good. I'll rub their back if that's what they want. I'm not going to bill the insurance. I'll let them pay me out of pocket for it because that's the experience they want to buy. But why are we not adopting this at scale? Like, why is every physical therapist in the country right now saying, hey, maybe I don't have to shoulder the entire burden. Maybe the patient can come see me instead of seeing the Hinge physical therapist through the screen, but we can leverage the power of the Hinge platform so that the patient can use Hinge and still come to me. The patient could use Hinge and still hire Dave. Hire Dave for the stuff that Dave does that Hinge can't do, but it's not all or none, this or that. It can be both, and we can manage it probably better than the Hinge people. Go ahead.
The answer is always it's one of these. It's never both. Or sorry, it's never is this or that. It's always a little bit of everything. What were we gonna say, Dave?
There's not enough Americans that want to use an app to get out of pain, or especially if it's a balance issue or some musculoskeletal issue or whatever. There's just not enough. Even though Hinge Health, what they do, 400 million or something.
I didn't look at the numbers yet.
But you can assume, I don't know what the number is. Maybe half of or some percentage of those people are using the app on a very infrequent basis, or they're using the app and they have like a small pain that they would go to YouTube anyway, or they would just they wouldn't even go to a physical therapy practice. So I just don't think there's a critical mass enough of people to use this. And we've had patients and clients, Tony and Jimmy, where they're traveling, they go to Florida, they go to other states, they go to other countries. And we've pitched them, especially like some of these out-of-network insurances. Some of them they have the parity pay, so that like they might pay us $300, $400, $500 a visit through out-of-network insurance for in-person visits, equally for telehealth visits. And even those individuals, now, of course, they're a little bit busier or whatever, but it's hard for us to even get these folks to do a telehealth visit. Most of the folks, and maybe it's a New York City bias, I don't know. Maybe it's different in other states, I don't know. But the folks that we interact with are like, they just don't take it seriously enough. They're like, how can that help? Now, of course, again, we talked about if it's triage, if it's, clinical questions, is it, what do you think of these shoes? What do you think of this mattress or pillow, or like a consulting type of call? Okay. But in terms of taking someone through a normal treatment visit that you would treat them for total knee replacement, Tony, or whatever it is, I don't think there's enough people to sustain a digital experience for aches, pains, musculoskeletal issues, whatever, which is why this company will not be around in 10 years. And if they even IPO in 10 years, if they're even around, their stock price will be $1 or $2.
You going short? You going to short the IPO?
I should. I should make some money out of this.
I like it.
Go ahead, Jimmy.
I like it. I like where you're saying. Yeah.
This is not investment advice. Speak to your lawyer and accountant.
It's not an investment.
No, I just think, I think the market's going to change. I think everything technology is going to change. If you go to the S1 filing, I think the greatest value we can all take, the people watching this right now today, is you look at the risks that they have identified, because these are the same risks, whether you're a single owner operator or you're looking at, starting an operation that's going to grow to 10 million in revenue. Look at the risks that they identify. Like, for example, it says, I'm reading on the screen.
And there's a lot.
It says, we have a history of net losses. We anticipate increasing expenses in the future. Like, how much have we already talked about therapists that are amazing therapists, deliver amazing therapy services, but they're undercapitalized. They want to go into business for themselves and they can't even afford an EMR. They can't afford marketing. They can't afford, a compliance program. Like, these are the risks that are going to put you out of business, not being a bad therapist. Everybody is more than like adequate at being a therapist. There were some in here that mentioned, we're dependent on our marketing team if we can't get new patients. And it talks about marketing. There's stuff in here, results from operations are fluctuating. They talk about compliance and regulatory risks. If the laws change, if telehealth goes away, things like that. If I was starting a business today, even if it was a real like in-person mobile or brick and mortar, I'd go to this document. I'd pull all of these risks out. I'd put them on a spreadsheet and I'd start addressing these risks for myself so that I can start to see into my blind spots, because I guarantee most of us aren't thinking about these things. So I would just lean on their legal team to help me look at the future.
Well, let's do that.
They're also, real quick, they're also just trying to get market share, right? So they're like Uber, like they're not trying to be profitable. If they wanted to be profitable, they would they would just spend less on marketing. They would, cut some staff, whatever. All of a sudden they could probably be profitable just like Uber, but they're trying to get market share. They're trying to, beat Sword Health and all the others. So that's why they can not be profitable. And I don't know if there's a great comparison to the outpatient clinics that are also with tight margins, but they're like Tony said, they're paying for their EMR and all this other stuff, and the overhead of the office or whatever. So, but that's just my take on, like, they probably could be profitable, but they're choosing not to.
Yeah. Yeah.
So Jerry asked, what does the future look like to all of you? Dave gave a prediction of Hinge Health. It looks like it won't be there in 5-10 years is what he's saying. But what do you think?
It will not be.
Is it going to look like Tony's clinic, where it's going to be?
No, it's going to go out of business completely.
All right, but what does the future look like?
Physical therapy. All right, well, yeah. Let you guys start. Go ahead.
Yeah, Tony, what do you think the future looks like in terms of physical therapy? How's it being delivered 10 years from now?
I think the fissure, the crack in the foundation gets deeper and deeper until it turns into the Grand Canyon. I think we have companies like a Hinge who are out there to serve a population size, millions and millions of people every single month. Like, there's that service. And then there's a service like Dave's got, where it is highly specific, very targeted. These are the consumers that are willing to pay, able to pay for the service that I am wanting to deliver. I think my practice, the 25 years, we're gone. Like, I think we don't exist in the future 5 to 10 years from now. And that's okay. We shouldn't exist. We are a model of inefficiency. Why should a consumer, whether it be Medicare as the consumer, the patient as the consumer, why should they pay for my inefficiency? If I can't make my product cheaper, more accessible, better, quality outcomes, I should go out of business. That's the whole idea of the free market. I shared a screenshot yesterday of a television back in like the 80s compared to a flat panel today. They're better, they're bigger, they're cheaper, and this is not even adjusting for inflation and other stuff. Like, why can I not deliver a rehab program for a post-surgical rotator cuff repair, post-surgical total knee replacement cheaper today than I could 20 years ago? I could. This is the inefficiency of healthcare. I'm too busy with compliance, with regulation, with making sure I'm not breaking the law. My patient care experience is like 47th on the list because I'm trying to stay in business. Eventually, I just need to go out of business.
Well, really quick, because I want to hear what Jimmy thinks about the future. But Tony, you're adding, you added Shockwave, you added some of these self-pay services. So if you stay with the in-network contracts in 25 years, you're not going to be here. But you're adding self-pay services to avoid that, correct?
Yeah. So my business, the business today is gone. I say in 3 to 5 years, not 25 years. The new business that I'm building will be there for the clients, the consumers who are looking for a self-pay experience that insurance doesn't cover. I do believe that's the future. Now, is that physical therapy? I don't know. I don't care. I don't plan to label it as physical therapy. But that's where I'm going to meet the consumer, where the consumer is.
Scott thinks the future is hybrid and cash based. Without Jerry commenting, I can hear him screaming in Philadelphia saying, "It's all cash. It's all cash. It's either cash given to you that you gave to the insurance company that they gave to your physical therapist, or did you give the cash directly to the physical therapist? It's all cash. It's all cash." My future is sort of what Tony was saying, and I'm cheating because why wouldn't I cheat? I just got on a plane.
You got a prop. You're pulling up something yellow. What was this? There we go.
Yeah. I'm reading this great book. This book is from a guy named Hamant Tanaje. I should know he's on the board here at Othello. So I figured if the guy's going to be on the board of directors, if I'm ever going to rub elbows with this guy, I better have read his New York Times bestseller.
Love it.
He's on. This book is a few years ago, so I'm late to the party. But the cool part, it was written a few years ago, and dude's batting like 78% on his predictions. So it's kind of a cool way to look at it. Is all the things he was saying, 85% is true. He's saying it's not and I think we just saw some news about Walgreens this morning too, which I don't even think we tipped off. I think they're going private. So the idea is unscaled, which is you don't have to be this massive thing. You don't have to be Hinge. How do you do the opposite? How do you use agility and dexterity? You don't. He goes into why you don't need a lawyer, right? Because you can have a legal service on demand and just pay them for their time. You can rent that. You don't need to have a gigantic server. You can rent whatever computing power you need from Amazon Web Service. So the future is actually the opposite of big and giant and unwieldy and trying to turn a battleship. The future is small and hybrid, and whatever needs to be done, I can do that quickly. The opposite is unscaled, and that's the book that I'm reading right now, and I'm about halfway through.
So Dana's here. Dana said therapists need to be regularly embedded in advanced primary care so we can normalize. So we are normalized as part of the mainstream healthcare delivery. That's how we offer more access to more patients at the right time. And yeah, I totally agree. Whether that's done as an independent provider that gets embedded into the team, or that's done as an employee of the team. You know, you guys know the story, but 2009, we were approached by an orthopedic group that was putting together the spine center. It was orthopedic surgeons, pain management, MDs, psychiatry, massage, chiro, and they wanted us to come in and be part of this holistic group. Now, we said at the time, we're happy to come in. We're not going to be an employee of the spine center. We are going to be independent. We're going to own our portion of the building. We're going to own our business. We're going to take outside referrals. But, you know, for the time that it existed, it was an awesome experience. I could walk literally down the hall, talk to orthopedics. We could have, you know, like a care team meeting. We really, I believe at that moment, provided the best level of care possible because everybody was communicating on an equal footing. Unfortunately, that business model went bust, but it's not because of the lack of care. It was because of poor business planning. And so I agree with Dana. I've been in that world. I love that world. I think it's great. I don't know, though. I will say, I don't know, though, like me today with the business focus more than the patient care focus. I think that's an amazing world for somebody who wants to be an amazing therapist and operate at the highest level as a therapist. I don't want to do that today. I'm not the best person, but I can build a platform and put a great therapist in that role. And I can pay that therapist, you know, a great salary and let them operate at the highest level.
I'm all about primary care or what did she call it? Direct primary? What was her term?
Primary.
Yeah, she said advanced primary care.
So, yeah, I mean, like my top physical therapist is just starting the other night to learn diagnostic ultrasound imaging. And we're going to leverage that to obviously advertise direct to the consumer, and then also be able to potentially build better pathways with referring physicians like concierge physicians and other doctors and podiatrists that are already out of network or self-pay or direct pay or whatever you want to call it. So practicing at the top of the license, I think imaging is somewhat in that ballpark, in that discussion for musculoskeletal issues. And that's one thing, like, I totally agree with that. Now, I know Dana usually comes with like a different approach of like her involvement in other organizations with like physicians, and that could be great because of like the feeder system with referrals and all that. but we don't want to be in some other organization. Like we want to be us so that we can be nimble and make our own decisions and all that, and have the referral partner connection with different physicians and referral sources.
You want to be in the same armada, but you don't want to all have to necessarily be in the same Navy. It's like, let's just sail together until it's not advantageous, then we can leave. But if we keep scaling up, which is like, let's get agreements, that comes with bloat, right? It's like, well, now we've got to have a compliance officer. Now we've got to have a marketing team instead of having a third party it out. It's like, there's all this bloat. I used to hear about it in academics, and I think it's very obvious in academics if you talk to people in academics, and it gets big in business. Like, there's entire teams at huge companies. And I think the companies that'll survive are going to be agile and lean, and they're going to be unscaled.
So Dana said advanced primary care paid 100% prospectively and higher reimbursement levels. This is where the reimbursement is going. Time to spread the word. She said we need to be a part of it. What, Jimmy?
She's good. Is she getting at, Dana, are you getting at value-based care? That's what prospectively is, right?
Yeah.
Say it, dumb it down for me. Dumb it down for me. Value-based care.
You're too smart.
You taught me all about value-based care. Make sure you keep using the words so I know we're talking about the same thing. But listen, I proved that we can do this, so I'm going to do that, and I'm going to get paid accordingly for that if I'm saying that. Yes.
I think this is the biggest barrier to the profession. Dana said that's the barrier. Oh, I swear I did not read that before I posted it. She said that's the barrier to our profession, silo thinking. I totally agree. And I'm guilty of it 100%. But I see it even more so in other providers that are out there. They don't want to share. They don't want to play with other kids. They want everything to be kind of under their own control. And yeah, that's a tough situation.
Paid monthly in advance is the highest level. So somebody, you would get paid. I'm going to oversee, John Doe for 12 months. So I'm going to be paid in advance. And if I can keep the cost below what I'm paid, I keep the difference, is what I think I'm understanding. They can't afford it, but they can't afford it.
We can't.
Yeah. They can't. Oh, sorry. They can afford it. We can't. Yeah.
Yeah. The big payments are going out, and we're not part of it. And so, again, I go back to, I think the clinician that wants to be more involved in patient care, that's where they should be. I totally agree. Like they should be in that meeting. They should have a seat at the table. They should be involved. The therapist who doesn't want to be part of the day-to-day patient care, the therapist who wants to build a business outside of that, it's just not for them. But then that's where I go back to, it's like, well, what the heck? Do they even need to be in physical therapy? Like they want to build a business that satisfies a pain point. It doesn't matter if it's a physical therapy business, especially as we lose the benefit of licensure, as we are not printing cash because we have 2 or 3 letters after our name. Now there's even less of a reason to label it physical therapy, to call it physical therapy, to have physical therapists deliver the service. Hello, back to the top of the show with Hinge. Like, why would they even want to limit themselves to saying this is physical therapy? Because then you fall under the state licensure and all the other stuff.
All the hoops. Yeah, we did an episode on that, which is it actually more restrictive to be a PT versus not? Because as soon as you say I'm a PT, it's like, well, with that, it's like Spider-Man. With that power comes great responsibility. It's like with that power comes with that little power comes great responsibility.
Dave?
Well, I mean, we all have gone into physical therapy school. You come out of physical therapy school, you kind of try to find your way and all that. And then eventually 3 years, 5 years, 10 years, whatever, into the profession, then you realize like, holy moly, all these issues. If you didn't know ahead of time, reimbursements declining. There's all this, there's ACOs, there's the hospital networks that are saying, like NYU and all the other ones that are saying, hey, let's keep, to all the physicians, hey, let's keep all the referrals in network. Let's keep all the referrals in the hospital system. Never refer to private practices. It happened with Tony. It happened with practices all over the country. Then you find out about all these issues. And then you're like, well, I don't want to do volume. And so I'm going to be self-pay or out of network or hybrid or whatever you want to call it, and actually do one-on-one care and not be a mill or factory or whatever. you get into the profession and then you realize like there's all these other issues and these challenges. And then some of them start to leave. And then some of them have done mobile, brick and mortar, whatever.
Dave should speak on the first day of PT school admission cycle. Be like,
No,
hey,
no,
you
because
apply
no,
to PT school?
the schools wouldn't want that because then
Of course not.
they'll
This
have
was
students
not on the brochure.
leaving.
But that's the thing. Every time CAPTI, is it CAPTI that does the
Accreditation?
the application? Well, like
Yeah.
the what's the portal? Whatever the portal is that you do the applications with, there should be a pop-up with Dave's, that last 30 seconds of Dave. Like, I know you're going in for this, but let me make sure all the fun stuff and the non-fun stuff is on the brochure. Understand, we're all about like financial transparency. Like, understand what these loans mean. Like, you should understand what these loans mean. Understand what the profession looks like before you go into it.
Well, and the students didn't understand the loans either. Like,
No,
I'll
that's
be
what I mean.
honest, I didn't know
That's
what
what I
that I didn't know what that fully meant
No, you
until
bought
you
the-
have the full balance.
You bought the dream, baby. I'm gonna be a do-gooder. I'm gonna do good. You know, I get to go to dinner parties and tell people what I do, and I get to stand there and bask in the glow. And then you get there, you're like, I don't want to talk about it anymore. You're not making any money. You're like, what? This was not on the brochure.
So, talking about this comment from Dana said, patients go to primary care and we are barely there. I wonder, when I started back in 2002, 2001, it was all about direct-to-physician marketing, right? We didn't have social media. We didn't have anything like that. You were going to spend a ton of money on trying to run newspaper ads, or you go straight to the physician. The theme changed somewhere in, the mid 2000s, later 2010. Stop physician marketing. Physicians won't send you referrals. And as we stopped physician marketing, I think we also lost those relationships, because to Dana's point, I still in that world, I would bring food. I'd feed the whole office, 30 people to get 3 minutes with the doctor one-on-one. But that's when I built those relationships with that orthopedic, primary care, whoever it was, to the point where now, I've got their cell phone number. I can communicate with them directly. They know that when something happens, they can count on me. They can send me a patient today and I'll get them in an hour after the call. I think we lost a lot of those relationships when therapists said, I am going to stop marketing to physicians and only go direct to consumer. What do you guys think?
It's never this or that. It's always that, and it's always and.
Well, like I just said, across the country, Tony, they lost the relationships also partly because of the ACOs and all these hospital systems saying, don't refer to private practice physical therapy. I would love to hear if Dana has a response to that, because what happened. It happened to owners all over online, that they've said it all over for years, 5, 10, whatever years. So whether it's and also the hospital system started buying up the independent mom and pop internal medicine primary care physicians. They were buying up those practices literally to buy the patient, the book of business, the patient list, so that they can keep those patients now in the hospital system. The hospital system gets bigger in terms of a bigger reach. And then they're like, just refer to the hospital-based physical therapist and make sure you refer them to, ortho and neurological neurologist or whatever, before, get the imaging done, ramp up the bill before even considering physical therapy, regardless of whether the physical therapy is the hospital-based physical therapy office owned by the hospital or externally.
But I would say every physician except one in my area, orthopedic and primary care, are all hospital owned, but we still get a ridiculous amount of referrals. Now, they are under pressure, 100%. They're under pressure. They're told by management and administration, you have to keep these referrals in-house. You have to send them to our own therapy providers. But even with that pressure, we still get more referrals probably than we can handle. So I don't think that's a reason that therapists should say, I'm not doing any direct to physician marketing. Again, I think those relationships are important. This was a great comment from Jerry. Jerry said, the biggest expense in physical therapy business, the physical therapist. Guess what you can cut in expenses, or guess where you can cut?
Well, this is what Tony was talking about. We were talking about months ago, which is like PT should be doing the PT things, which is the eval, right? Surgeons should be doing surgery things. Why isn't the surgeon checking the wound site after, a week? Because that can be delegated to someone else.
Why isn't the surgeon calling the patient to remind them that they have an appointment tomorrow?
Right. Why isn't the surgeon, if your name's on the sign outside, Dr. Surgeon Smith, how come you're not doing the text messages and you're not answering the phones? Because he wants to be at the top of the pyramid, practicing at the top of his license. And PTs, for some reason, like to climb up and down and then get annoyed when they're paid for doing the lower pyramid things.
I want to hit Dan's question.
Yeah.
It's a good one. I already forgot what I was going to say. Dan,
Well, I'll read. I'll read the question. All
Yeah.
right. Dan Vapney, who's doing something different. I had an interview with him not long ago on Long Island. He's trying to group people together for leverage. So Dan asks, do you think the pendulum will ever swing the other way? And if you say no, you're an idiot. Never say no. Always say, well, maybe, right? Always be in the middle, right? I'm going to say that's probably supply. As supply of clinicians continues to dwindle and access gets more restricted, so supply is going down and demand will probably go, and access is going down, demand might go up. As people use Medicare less and providers continue to not participate, will it ever go up? Is there a way?
Will what go up?
I'm guessing payment. I'm guessing money. But Dan can correct me. I don't want to put words in Dan's mouth. Because he's talking about supply and demand.
I don't think so. No, reimbursement's never going to go up.
It's got to go up a little bit at a respectable rate.
I would agree with Dave. I don't think reimbursement's ever going to go up. I don't care how much we lobby, how much we push, how much we bribe. It's just not. That's not the way it goes. It's going to go down. Even if it did go up a tick relative to inflation, it's still going down.
Yeah, that's sort of what I meant. It's like it's gonna go up, but in the grand scheme. So like if you're listening to this and you're saying, well, I'll just hold my breath and wait for that thing. Again, I'm not saying don't advocate and don't do all those things. That's nice. But what else are you doing? Like if the boat is sinking and you're hoping for the Coast Guard, but they're 500 miles away, dude, start paddling or start bailing the boat out. What are you doing differently to move that thing forward? Like doing things like Dave and Tony, who are doing different things respectively, but they're doing different things. I'm using air quotes on a podcast. Doesn't make any sense, which is, well, I could just continue to do what 89% the middle of the bell curve is doing and get the same result. Or I could bring in equipment like Shockwave and thing, or I could go direct to consumer and cash-based concierge. There are more than these two guys' ways to do it on the screen. These two are not saying these are the only way. Like you guys aren't guru, like you're not selling, this is my way, buy my book. There are ways to do this, and I'm sorry, but that old way ain't it.
So to the pendulum question, yes, the pendulum's absolutely going to swing. I think people like Dana are going to lay the groundwork for where we can get paid more. We can have more active participation in the entire episode of care, in the consumer, service, like all that kind of stuff. I think the reimbursement for CPT code 97110 goes up? No. Do I think therapists make more in the future? Yes, but I think it's a new model where leaders like Dana are showing us where we can be, because before she came on the scene, I had no idea that these were options that people were thinking or going this direction. So yes, the pendulum's going to swing, but it's just going to swing to a different area. It's not going to swing back to where we were in the 70s, where therapists were generating $400 or $500 an hour for eStim, ultrasound, TENS unit, ice packs, and a little bit of exercise.
Thanks for ruining it. People back in the day.
I don't know. Patients like it. Patients like the modalities.
I know, but what I meant was like the overbilling and all the stuff back. What was that? Was that the 80s?
Yep.
90s?
Yeah. 80s, 70s. Jeremy Sutton is here.
Jeremy.
He said, was told by a teacher in PT school that we should be making six figures and driving a Mercedes in 4 years of after 4 years of graduating. I have a few words to say to her.
Yeah, sorry, man. She sold you the hole, and then you bought the drill, and then you got a spoon to dig a hole. So I'm very sorry.
Yeah, Dana said the CPT codes won't be determining reimbursement. That'd be a beautiful world.
There you go. So that, the whole value-based care, it would be just what, like we talked about it briefly. Maybe we have to have her on for another recap.
Let me see if I can quickly do it, but definitely have Dana back on. essentially it'll be like, here's this diagnosis, you're taking this on. We now go into partnership, the payer
and
the provider.
like a time window, maybe.
Yeah. So I'll give you Tony's a good example. Total knee replacement for this person, this age, all the factors that come in. We'll pay you this because it should fall in this bell curve of how much of your effort I'm going to pay you this. And then you're actually reverse incentivized, right? Because like PTs are are incentivized to keep you not get like, I'll keep you for 6 months when I should do it in 3. This is like, I'm going to give you all the monies up front. Get it done faster. If you want to keep them around for 9 months, that's cool, but that's on your dime. I'm not paying you more for that.
And magically, utilization will go down for outpatient physical therapy.
Everybody's getting better. No, yeah. But that's skin in the game, man. That's a fair thing to say. When we walk around and we beat our chest and bang the drum and say, we are this and we are this. And then if people would be against this, I'd be interested to go, you can't talk out both sides of your mouth. We're so great. We get people better. We're cost effective, and then say, great, then we'll pay you per diagnosis and say, within this time frame, this is the money you have. If you do it, and the better therapist can do it better, faster, you'll keep more of the money. But go over that, unless there are extenuating circumstances, which I'm sure there's, things, codes you can enter. What policy?
I don't know if Dan and Dana have connected. Dana is Future Proof PT. But if you guys haven't connected, I think that'd be a great connection, and just listen to each other, talk to each other, because you guys are both doing great things. The thing that I always look back on, and I don't even know, these guys probably know better than me. You always hear the stat like, well, physical therapy saves money in the big picture. Physical therapy reduces the chances of surgery, all these other statistics. It just reminds me back when therapists were trying to directly market to employers, saying, look, we make a healthier workforce. You're going to save money on the back end and all these other things. I don't know how effective those initiatives are. I do see Hinge in that world. Like Hinge is working directly with the employer.
I was just going to say Hinge.
Yep.
Yeah.
And I would say, just like we've said before, like we see Hinge for what it is today. I don't know if it was Hinge or Sword or whoever, they were all virtual, and then they started doing mobile visits, or somebody started doing that with real people. I think the businesses are all going to evolve. They're all going to change. Look at where Uber was when Uber started, Airbnb when Airbnb started. Like those businesses are nothing today like they were when they started. So to round the show back to where we opened, whatever Hinge is right now and at the IPO, it doesn't matter. We have no idea where it's going to go, where it's going to be in the next couple of years. And as AI advances, massive changes are going to come to everything. So we're making speculation on something that might not even, resemble what we're talking about today.
Wow, we got Carrie from Down Under. She's saying that Australian PT, 90% of their work is private pay. Plenty of room in the markets for many services at different price points. Isn't it funny how the water finds its level? If this is the way it is, water finds its level. Carrie, thanks for listening in from Australia. I didn't think this microphone got that far.
Jerry said direct to employer is growing. Now, Jimmy, we have a mutual contact that I didn't even realize, Rick Wickstrom.
Oh, yeah.
Did you
APTA
see him
Orthopedics.
at CSM?
Yes, briefly. Yeah, I walked by him, but I worked with him with APTA Orthopedics on a couple projects.
Yeah, so Rick's a local guy. I know you know.
Oh, yeah, he's from Ohio.
Like literally, I remember when I was scouting out the area back in 2005, 2006, I looked at where Rick has his clinic. And I didn't know Rick at the time, never heard of anything that he was doing, but I thought about opening a clinic, and then I found another clinic there, and he was the one that was there. I connected with Rick in the future. We've become great acquaintances. He taught me how to do like FCEs and other work stuff. But he's doing really cool stuff, and nobody even knows about what he's doing.
He's creating a 3-part certification for people to work in occupational health. Essentially, if you want to go direct to employer, you want to go work, you see that Amazon warehouse down the street and you're like, that should be my contract. I'll go keep those people healthy. he essentially was saying, well, here are I think he did a 3-part certification through APT Orthopedics to get the letters after your name, but really to make sure you know how to approach that and do it well.
Yeah. Yeah. Like he's been in that world. I know for a while he was doing the fitness testing before you hire a new employee and a physical therapist. It didn't have to be a physical therapist to do the screening, but then if it triggered, these results, the physical therapist comes in. And when we're talking about value and like putting, a multiple on the value. Yeah. Like if I'm an employer looking at hiring somebody who's potentially a high risk of hundreds of thousands of dollars or workers' comp claims down the road, I'm going to spend $500, $1,000 for a physical therapist to do a pre-employment screening for me. There are just so many areas that we can leverage our experience and our knowledge for the money that, we want to make that have nothing to do with Medicare, Medicaid, worker, any of the other stuff.
Right. We hit a lot of that. So I wanted to bring something back up from last week when I talked about RCM, which there's a lot of letters we've been hitting today. RCM, AM. So Dave, you and I were talking about RCM. I like how in the beginning of the show, someone was like, now Jimmy knows all things RCM.
after an intensive 10-day onboarding.
Hey, at this point, it's 2 entire weeks, bro.
You're good. You're good.
No. So I like where I am, which is like I know enough to be a little dangerous, but I'm smart enough to be like, dude, there's a lot of smart people. But Dave, we got to the point where you're like, hey, listen, I'm on the fence, or I'm thinking about this. Let me use something like Athelis for like a week or two, and then I'll let you know. And I wasn't smart enough to know we have something like that. Now, setting you up for like 2 weeks. The amount of work that would be required to get all the right information, things being pulled, it wouldn't be worth your time or our time. It just wouldn't be worth it. What we can do is actually might be more valuable. Instead of a 2-week snapshot, we can plug into your data from the last 2 years and crank up the DeLorean and go back in time and go, hey, this is an estimation of if you were working with Athelis or an RCM company, this is what things could have looked like in the last 2 years. That actually to me was more valuable because it's a larger time frame, which you're going to get better data, and it's less involved and doesn't stop your current operations. Like you're not stopping, you're not stopping treating patients or making money. You want to be able to change the wheels on the 18-wheeler as it's still moving down the highway without risking it going off the road. So that is an option that I should have said, but again. I know all things RCM. I've been here for almost 14 days doing the thing. But I have learned a ton. Like I've jumped into the deep end, and it's kind of interesting when you get the power of AI behind fighting all the things, some of the things that we bitch about on the show. Yeah.
All right, let's think about parting shots real quick. Scott said James Pickle is doing great things. New Wave Medical Network.
I had James on a while ago. He's out really? Arizona, I believe. James Pickle.
I'll have to check it out. I don't know if he's the person. Somebody had posted on LinkedIn about Medicare should pay us $200 a visit. And I said, I understand where you're coming from, but I was thinking about that post again this morning. And I always default back to like James and Dave and anybody here, Scott, like you guys reflect a very high value service. But if we're going to try to say the taxpayer should be paying us universally more, we're also saying that the taxpayer should be paying every one of us more. And that includes the bottom 50%, the bottom 20%, I don't know that they deserve to get paid more.
When you start saying that, that's when I go, oh, shoot. Yeah.
You're taking money out of somebody's wallet and you're putting it in somebody's hands.
You're rewarding mediocrity.
To 10.
You're rewarding mediocrity, and not even mediocrity. You're rewarding the bottom third of the far left of the bell curve, which is like the poorest performing. When you say that, I'm like, crap. Because the people who are listening to podcasts, and I'm not just saying this because we host podcasts and live streams, but those are the people who are like, I'm not just clocking in and clocking out. I'm leaning into this. How do I become better? How do I solve this? All of us. Yeah, of course. We're doing this. But yeah, you do have to like look at that and say like, oh yeah, when the rising tide lifts all ships, it lifts the dinghies too. It's not good.
All right, I'm going to take Jerry's comment as my parting shot. Give me 1,000,000 lives to manage and give me $5 a life to manage them. I've heard this saying before in a different way.
haven't.
You know, if I want to earn $1 billion, let me help 1 billion people for $1.
$1. That's
Yeah,
cool.
it's just like at scale, we can absolutely make the money we need. I don't need $1 billion to live a happy, fulfilled life. But the idea is there's things I do for money, and then there's things I do for fulfillment. Sometimes there's overlap, but it doesn't have to overlap. It doesn't always have. I will go clean a toilet that's clogged if, you know, that's what needs to be done and somebody is going to pay me the money to do it. I don't have to love it. My wife always says, do you think I love doing laundry? Do you think I love picking up the same socks and the same shoes 20 times a day? I don't love it, but I do it because that's what the house needs, you know, to operate. We don't have to make our money doing what we love, but if we make the money, we can do what we love later or separately. They can be separate things. That's my parting shot.
Dave, what's your parting shot? I got a fancy one.
Yeah, parting shot. Maybe there's a chance, maybe there's a place where some of these digital companies, Hinge Health, Sword Health, etc., are an option. I believe for the consumer, I think it's low value. I think most consumers will not truly take it seriously moving forward. I think eventually the employers will say, actually, yeah, this is something that like our folks are not using or not benefiting from, or they could just use YouTube videos and random, Instagram videos from Tony Maritato and Total Therapy Solutions. I just don't think it's going to be around. I think if it even goes public, it will have a way harder time being public than Uber did. And Uber was one of the biggest ones that went public that was not profitable. But again, they were doing the same thing with market share and trying to out compete Lyft. And Lyft is still around, and Uber is still around. I just don't think in the long term, Hinge Health or Sword Health will be in existence in 5 or 10 years.
Reading this book, Unscaled, that I mentioned there before. I'll drop the link in the comments if you want to take a look at it. But it pairs with my parting shot, which is perfection is achieved not when there is nothing more to add, but when there is nothing left to take away. We talk a lot about what should I add to my practice? I'm going to bring in an alter G. I'm going to bring in this. How can you go the other way, right? What can you take away to make yourself? Is addition by subtraction. How can you actually leverage things that are unscaled, smaller, faster, more agile to actually add? Do you need to buy the thing, or can you rent the thing? Can you borrow the thing? Can you partner? Do you just need to be a formal partnership, or can it just be a loose partnership? So ask yourself what you can take away, right? Talk about how to make more money. Could you spend less? Have we looked at that? So reading this book, and I'm about halfway through. I'm on the unscaled wagon right now.
All right, guys, go check out Dave Kittle Show, PT Pinecast, Learn Medicare Billing. We are back Tuesdays and Thursdays at 8:30 a.m.
One more thing. If you're in Denver, I'm throwing a happy hour in Denver on Thursday. Details on the socials. Thursday night at a place called 14 taps, 14. I don't know. My roommate from PT school picked it, but I'll share it on the socials.
All right, guys, we'll see you next time.